last month. So until I see that still some is coming, joining us. And just want to mute. So let's start pediatric imaging with chest part. Maybe a few cases from chest, then we can shift. Pediatric is more frequent in exam, that you will have some cases, and for the FRCR also they like it because you should be safe for the pediatric age group. So what do you think about this when you have chest X-ray and of a skeletal immature patient? How you can approach this case? So first approach, you can ask yourself, is it like a term or post-term? Is it a pre-term or post-term? Yes. Ala, welcome. Thank you for responding. Okay, bilateral lung opacity. Yes. So Nermeen, welcome again. So your expression nice that you mentioned lung volume. So you should note two things, either to try to figure out the age and the good or bad condition. Is this patient have, for example, any tubes and lines or ventilation? And then try to figure out if you have any lines, tubes, or he look like ill, very ill patient, or he look like good. Also, the nice thing that you mentioned, that is it like lung volume, is it increased or decreased or normal? So you can describe it in two terms, either increased, or you can put the normal or decreased in another category. So if you consider it like increased, I will show you something like it should be like the normal one. So maybe the same age, the same patient, 4 days ago, he was like this. Then he developed, he developed this 6 hours from birth, but after 4 days, he become like this. So how you describe it? Yeah. So your differential will be transient tachypnea of newborn, or yeah, or Marwa, welcome back. You were absent, was absent many times, but okay, welcome. Yeah, meconium aspiration. So you have, when you find good lung volume, that you will mention meconium aspiration, or either it is TTN, transient tachypnea of newborn, or which one of pneumonia you would like to mention. You will describe Streptococcal pneumonia or non-group B or non-group B. Which one is with the non-lung volume? Yes, with the good lung volume. Which type of pneumonia you like? They like this MCQ. So you should just be aware of this division. Non-group B or group B, streptococcal pneumonia. Yeah, non-group B, perfect, Marwa. So non-group B, this will be the differential of TTN and of, yeah, and meconium aspiration. So this one, he have post term again, and you can see that this patient already, they insert something here, which is, yes, yeah. So here you can put meconium aspiration, that this patient need treatment. Yeah, so Differential again will be TTN, especially the severe cases, or pneumonia but non-streptococcal pneumonia. Again, especially when you find these opacity are very hilar, then you are talking about, yeah. So, yeah, this is the endotracheal tube. Yes. And this patient, when he was normal, and this patient, again, the endotracheal tube, and you can see the very hilar opacities. Sorry. So, yeah, transient tachypnea of newborn, this one, and after that he become clear for days. So transient tachypnea of newborn, yes. In the chest X-ray yearly, it takes 2 to 6 hours. That's why he mentioned the MCQ here that already it was 6 hours. And they like to mention in the MCQ that the history have something like cesarean section. Okay. The fluids, it like to be in the fissures. That's why you maybe you can find like streaky like opacities, and yeah, after that it can become clear, like this patient, and he after like few days become normal. Okay. Meconium aspiration at this case, and this case they like the very hilar region, but again it is differential diagnosis. The most important to know that this patient will be term and good lung volumes. Something called the ECMO in the treatment if severe. The same is used in now. What is the ECMO? Do you know anything about it?
Extracorporeal membrane oxygenation.
Perfect. So this is what is called extracorporeal, yeah, membrane oxygenation. Yes. So let's just have a look, because it is importance now is maybe much. So why? Do you know why? Where it used? Why?
Cardiorespiratory failure.
Yeah, and especially they like to use it now with the COVID patients, COVID-19. So just to know about it and how it look. So the most common types to use veno-venous and veno-arterial. Okay, I just want to
one in the brachiocephalic, other in the subclavian.
Perfect. So just I want to show you how it can be in the, yeah, to just be familiar with it. Yes. So you can see this like tubes, right? These tubes, and maybe I can show you the, yeah, this is the extracorporeal membrane oxygenation device. Okay, I want to maybe show also another example for it. So let's show this one. Yeah. So where do you see this? Okay, right? So this is the venous type, right? Okay, and just to be familiar with this appearance, that maybe you can see some like endotracheal or the tracheostomy tube, some central venous lines. Okay, but this is what is called ECMO, and they like to put it in the venous side like this, veno-venous. Okay, I just maybe I just mute. Okay, and I want to just come back. Yeah. and it can be like they have many examples for the ECMO. Okay, just important to know about it, and the position and also the double lumen cannula for veno-venous type. Okay, let's go back to our ECMO, to our meconium aspiration, and something good to know that that they have pneumothorax and pneumomediastinum in 25% with hyperaeration. So you should see increased lung volume as we mentioned here, okay? And here again. So if you now become familiarized with this, so again, what is this one? And how you describe it? Yeah, opacity is very higher. So now you will think about either meconium aspiration or pneumonia, perfect Abbas, which type of pneumonia? The non-group B type. And what happened here? TTN and meconium aspiration. Yeah. So what happened here with this as a complication? If we consider it like meconium aspiration, what happened?
Pneumomediastinum.
Perfect, Ala, perfect. Marwa, I think Marwa. So it would be pneumomediastinum.
Yes.
Okay, so nice. So what is this? What's this device? And what they won't show you here. Yeah, this is the ECMO. And they won't show you that this patient with meconium aspiration, they treat him with ECMO, and as you see that the lung become like something white out, like you can see that lung is almost white in both sides, yeah. And let's check about the endotracheal tube. So what is the best location or the proper position of the endotracheal tube?
In pediatric population,
Yes.
1 to 3 cm above the bifurcation of the trachea. 1 to 2 cm.
cm
1
above,
to 2
above
cm.
what? Above what?
About the bifurcation of the trachea.
So you mean the carina, right? So you for example, you will trace
Yes.
the carina, and you try to get it like, yeah, around 2 centimeters above the carina, right?
Yeah.
And in the adult, they mentioned that it could be like 5 centimeters plus or minus 2 centimeters, right? Everyone agree? Yes, 5 centimeters. So just to good to know about the lines as well. So there is umbilical venous catheter and umbilical arterial catheter. So the umbilical venous go in the left portal vein, ductus venosus, hepatic vein, IVC, and the proper position will be the cavo-atrial junction of the vein. And the arterial one through the internal iliac. So the most important difference between both, that you will see that it go down, then go up along the internal iliac artery, then common iliac artery, then the tip either above or below. So T8 to T10 or below L3 to avoid the branches of aorta. The peripheral inserted cannula or the central line, again the superior vena cava, the endotracheal tube at level of clavicle, and the nasogastric, it will be below the EG junction line. Okay. So just to know about the, for example, here the nasogastric, yeah, and endotracheal, and so on. Okay. Yes. Again, this, if you consider him like full term, And you can also confirm this with the ossification of the humeral epiphyseal parts. Okay, so you can think that he is full term, right? Again, this you can see the opacities in both lungs, and he give you history that already this patient have fever and so on. Note also the something here going in the clavicle in the right side, so it's fracture. So what is your differential? Again, pneumonia, perfect. And look that the patient is ill. Why? Because he have already like some tubes inserted. And yeah, pneumonia. Yes, pneumonia. Okay, so we just all know that there's something called group B, streptococcal pneumonia. The most important differential diagnosis would be surfactant. It will be granular symmetrical opacities, low lung volume. So the group B, it will be low lung volumes, which is the most important B surfactant. Non-group B, which like this one, which is the differential of meconium aspiration. Okay, is it easy? Okay. So this one we mentioned meconium aspiration. This one mentioned mediastinum. Sorry. Yeah. Come back on this one. So this one it will be pneumonia, and the most important to know is it low lung. So it will be like group B differential or high lung volume. So it will go with the other differential. So the other pneumonia, which is non-group B, it will be the differential of meconium aspiration. Okay. So let's try with you now. So if I told you that this is pneumonia, which type you would like to mention? Is it group B or non-group B? So try to find, is it preterm or fourth term? Yes. And he is like the differential will be surfactant deficiency disease or not. So bilateral, yeah. I think it will be group B, perfect. So group B streptococcal pneumonia. I know it's not easy. At least know it for the MCQ. At least know it for the MCQ, just know the differential, but also in the images, you can put like this one to look like good lung volume. And if it is good lung volume, so you are going to mention that, yeah, group B streptococcal pneumonia, or if he's low lung volume, sorry, if it's low lung volume like this, it will be streptococcal pneumonia group B or surfactant deficiency. Yes. Okay. It look like ill patient, many tubes, many lines.
Hyaline membrane disease.
Yeah, this is the most important to know. When you find this and with white lung and the lung look like low lung volume, so either your differential will be group B streptococcal pneumonia or surfactant deficiency syndrome. The most important to know here the prematurity. It look like telectatic or ground glass. Yes, hyaline membrane disease. And the most important therapy here it will be surfactant therapy. Is it clear? Yeah. So your approach again, look in the lung, check if there is any tubes or lines, start to comment on it, try to categorize this patient. He is premature or term, post-term. Yes. Then try to find the key or the differential. So
multiple lucencies.
Multiple lucencies, your history, you'll ask about the prematurity. If this patient premature, you'll most maybe take therapy. And you can see here that already he have something. So it can be complication of surfactant therapy. Yeah, either
Pulmonary interstitial emphysema or bronchopulmonary dysplasia.
Perfect. So you have now two differential, either bronchopulmonary dysplasia, which again the most complication with prematurity after mechanical ventilation and oxygen, or the other differential, okay, which will be congenital pulmonary interstitial emphysema, when you find much lucences, and again you can find some pneumothorax as a complication. So either congenital pulmonary emphysema, congenital pulmonary dysplasia, or bronchopulmonary dysplasia, or pulmonary interstitial emphysema. Okay, is it clear? Yes. So the finding, it will be maybe similar to each other, just maybe the history you can know from the history. For example, this one, it is bronchopulmonary dysplasia. Again, check for the lines and tubes, and then you can know that this ill patient, and from the history that if he's taking like therapy, then you can reach the diagnosis. For the MCQ, they will tell you that the therapy, the oxygenation, and so on, then you can suggest, yeah. Just I want to ask you something about this patient. Is it the lines of tubes here in good location or not? Yeah, it's not. Can I? Yes, it's not perfect. Why? Yeah, the endotracheal tube here, you can see, if we consider here the carina, so it exceeds 2 centimeters, right? Rim, perfect rim. Yeah, it's very up position. Yeah, and also if we consider the umbilical catheter, I think it should be, yeah, you can see something here. So it is, yeah, above the diaphragm. Yeah, so it's not in good proper position. Maybe we can just try to make, yeah, I will try to find it here, I think. Let's check some. So next, yeah. So this, let's check here, just to make just a bit confirmation about this one. So what do you like this appearance? This is the good position or not? And you already mentioned it, just to confirm that everyone have clear knowledge about this. Yeah. So good position or not? The endotracheal tube, yes, is good position. Why? Because you expect that the carina level, that it is in adult is about 5 centimeter, and pediatric about 2 centimeter, right? So you will check the good position of this patient. How you find the carina? This is a good question. They say that look in the, for example, sometimes you can find the carina easily, sometimes not. Look in the trachea and try to find the 6th thoracic vertebral body. It is almost there. or you can try to go by the reps. For example, here 1, 2, 3, 4, 5, 6. So it will be vertebra number 6 here. So it should be here. Okay. So the cranial position. So what about this one? What this? Try to figure out. I'm checking what you have. Okay. What's the name of this?
Tracheostomy.
Exactly, tracheostomy. You can consider it almost the same or just little above, maybe 6 centimeters above the carina, or you can consider it half distance between the top of the tube and the carina. So again, okay, tracheostomy is much important to know. Just I will go with you lines quickly, just to know that everyone is considering. So do you like this appearance? If you don't like it, what happened here?
No.
No, why?
Move it
Position.
down.
Yeah, this is very critical. So first of all, when you find any tubes and lines, you will check that the line on tubes is going in bad position. So here you can see that going in the right side, the right main bronchus, so it will make very bad complication. Okay, and again here, what happened? Do you like this appearance or no?
Low lying.
No, perfect. Why? Because again, you
Low lying.
yeah, low lying and it go in the right main bronchus. And here you can see the complication already happen with what happened here with the misdisplaced endotracheal tube collapse. Yeah, you can see that when he insert it is in a bad position, and you can see that left lung collapse happened. Perfect. And check always for complication. I show you the answer, but okay. What do you see here? You remember our rule when we find surgical emphysema, we search for. When you find surgical emphysema, yeah, pneumomediastinum. And when you find pneumomediastinum, search for surgical emphysema. So they are, yeah, together. So what happened here? Surgical emphysema, and you have line, endotracheal tube. Check the line, okay, but there is much air surrounding the mediastinum, so it is pneumomediastinum. So okay, there is something going abnormal in this case. Let's check for the esophageal part. So we consider that the gastroesophageal junction will be here, and this is the line where the nasogastric tube will be inserted, and this should be the trachea, and again the carina and the aortic knuckle. So what happened here with this nasogastric tube? Is it in good position or not?
Good.
Yes, it is in good position. So the tip should be here, and look for the gastroesophageal junction, and it go in good direction, and you check everything. Okay, Ala, perfect. So what about this one? There is any abnormality here? Until here, it's fine because it doesn't pass in any of the right or left main trachea, so it is in the esophagus, and it go in the good place where the gastroesophageal junction. But the missing here that you don't see the tip, right? So when you comment in it, don't say that I can't see the tip in good position, right? Okay, you cannot trace it. So you should mention, especially in the oral exams, that if he say to you it is good or not, don't say that is well, because maybe it is not well, okay? for example, okay, so this patient, yeah, when he show you the best of the image, it is going well in the left side of the abdomen. So it is going well. Okay? Yes. So let's show you this. What happened here?
Coiled.
Yeah, the nasogastric tube is coiled. So you can see the coiling happen, and at level of carina, that it go up again. So the normal tracing of this line is not going well. It go up. So this displacement or loop. And easy here, you can recognize that the nasogastric tube go through the right main bronchus. Perfect. Zoom user, thank you. Yes. And what about this one? Is it good position or not?
Should be introduced more.
Wow, yeah, perfect. So it should be in safe position. The safe position should be at least, if this is the gastroesophageal junction here, then you should introduce it more to the target. The target will be about around 10 centimeter distal to the gastroesophageal junction. So he should introduce it more near me. Perfect. Marwa, yes. So I agree with you. That should be here. Okay. And finally, you can see the tube displacement here, which going to the right side where the
duodenum.
Perfect. The site of duodenum. Perfect. So it goes from the stomach and across the other side in the right side where the duodenum side. Okay. Crossing the pylorus. Yes. Let's go to the catheter, and we already mentioned about the ECMO. So our target here will be the superior vena cava. So that you would like to see that the internal jugular on both sides will join the subclavian on both sides, and they will make the two, this, what the name of this, innominate or brachiocephalic veins, and they go to form the superior vena cava. And when they form the superior vena cava, the level here will be the carina, right? Again. So it will be the right side of the mediastinum. Okay? So should be in the right side of the carina, either above or below the carina. Yes, around here. And then after that, it will start the right atrium. And here it will be the cavo-atrial junction, right? Okay. So if we want to be more accurate about the cavo-atrial junction, it will be where? Yes? Around here, right? Yes. So they mentioned that you can, from the carina, calculate about 2 vertebral bodies, then you can find the cavo-atrial junction. So if this is the superior vena cava, just to finish, and just a bit distance, about 2 vertebral bodies, then you can find the cavo-atrial junction. So this will be your target, where to find the catheter. Okay? So do you think that this is good or bad?
Good.
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 Perfect. So you check the carina level, and you find it in the superior vena cava, right? Internal jugular vein, then continue until the superior vena cava. Okay? So it will be for example, chemotherapy or dialysis or whatever. So the anatomical location of superior vena cava, 1 centimeter above the level of carina, here. So it is a good location. What about this one again?
You should introduce it more.
I think is a bit fine because you can see that the carina is here, right? He introduced it from the subclavian and it go in the subclavian, so below the level of clavicle, then go vertical and 1 centimeter above level of carina, so it's okay. Still in the superior vena cava side, right? So it should be in good location. So what about the left side? Yeah, he introduced it from the subclavian, and again it go to the area where is it superior vena cava. So it is in good location, right? I see many response from Rabab, Reem, Justiana. Okay, thank you. So, and this is the BICC central catheter, peripheral inserted. Yeah. So you can see that the line is going here, and the target here will be the cavo-atrial junction, which is more with the long-term catheters. Yeah. The peripherally inserted central catheter is better to be in the cavo-atrial junction. So 2 vertebral bodies below the carina, so it will be in the cavo-atrial junction. So more good to be in the cavo-atrial junction. This is the preferred location if you will put like long. Yeah, we show you the answer. Okay. So what happened here? This patient, perfect. You can see the catheter is going well, but what happened? The pneumothorax happened here. So it is adequate position, but there is some complication when he insert. They make like a injury of the pleura, and this patient developed like pneumothorax. Yeah. And what about here? Is it an appropriate position or not? Justiana, thank you. Yes. Yeah, it is not. Why? Yeah, it is high. It should be in the superior vena cava area. So he go and insert it in the brachiocephalic line. So he should introduce it here. So it's not safe. So yeah, I agree with you. And what about here? Is it good or bad? The BICC. So this is the peripherally inserted central catheter. And we mentioned that the high or the long-term catheters should be inserted in the cavo-atrial junction. So it will be, the target will be here, but he introduced it in the level of the right atrium. So the BICC, yeah, it's going well here, but he introduced it more, so it is not good. And finally, what happened here? Is it good or not? From the left side here. Is not good because it should be in not horizontal. Yeah, horizontal position. Yeah, it go like this. Yeah, maybe it is in the area of superior vena cava, but the position is horizontal, not vertical. Should be like vertical one, not horizontal. So when it is horizontal, there is maybe will cause like erosion or injury to with the long-term use. So it should be in vertical orientation. Yes, exactly. So when you insert it, it should be in the good orientation. And you can note that the nasogastric tube is going well, but again, you cannot trace it. What happened here? Is it in good place or not? Not.
It is not.
Yeah. Where it go? Can you expect where it go?
Subclavian vein, left side.
Maybe, but it's going from upside, so it will be the internal jugular.
Ah, okay.
And you
Okay.
can note that the good location of the ETT, endotracheal tube, and here it go like in bad position. So yeah, the target will be the superior vena cava. Okay. So I think we now a bit familiarized with the most common used. Just maybe you can again this what is called the chest drain for treatment of pneumothorax. So where do you expect to see the tip? Superior position or inferior? You will consider it to be in a superior position. Why? To drain the pneumothorax. Perfect. It should be in superior position, as you see here, the chest drain, and it go in the superior position. Perfect. And nice, Ala. And the one for the pleural effusion, it will be down. So you can see that here the holes of the drain that should drain the air, yeah. And finally, you can see the tip. Yes, the radio-opaque tip, which is easier. You can recognize it. Yeah. Yeah, perfect. So, and this one for if it is in low position, as Ala mentioned, it will be the, yeah, Zoom user. We mentioned that the catheter, like the BICC, which is used for long-term therapy, it will be in the cavoatrial junction. Okay. Yeah. So again, the chest drain, which is inserted in the pleural effusion, will be in low position, different from the pneumothorax one. Okay. We're about to finish this. Yeah, you can see that the answer is easy. So, do you agree with this position here of this drain? Is it good or bad? Perfect. It is bad because we mentioned that the drain of pneumothorax should be in superior position. Rain, perfect. So this one, it should be for effusion. Yes, not pneumothorax. Yeah. When you find surgical emphysema, you will search for pneumodiastinum. Okay. And what happened here? Yeah, you can recognize here the drain now. So what he did for this patient? Yeah, it was in the chest.
Surgical emphysema.
Yeah, and it caused surgical emphysema. And you can see also easier the pneumothorax and pneumomediastinum. Yes, perfect. So let's just go to, I think we mentioned most of them. So just we will go to another case. To shift for another issue. Yes. What do you think about this one?
Metaphyseal fracture.
So what do you want to mention if it is metaphyseal fracture?
Non-accidental injury.
Perfect. Yeah, this is like a very anti-mini case. You can see it, and you like it in the exam. Perfect. As well. Yeah. So metaphyseal, it is a highly specific corner fracture in the lateral aspect of the humeral metaphysis. So when you find it, you are talking about non-accidental injury. Below 6 years, yeah, and most of them below 1 year. What you will need to do, if this patient, you find this, what you will go to do?
Full body survey.
Yeah, skeletal survey, including brain CT. Perfect, Roa. Nice, welcome. Survey, perfect. And also you will discuss with the clinician the aspect about this. So what is highly specific fracture that you expect to see? The metaphyseal one, right? Either in the humeri, like this one, or in the femur, or in the tibia. And if I show you this one, what do you like to see? Where and what is your expectation?
Rib fracture. Ribs fracture.
Yeah, but maybe you can be more accurate if you mention that it is in the posterior rib fracture, then it is more.
Yes, it is posterior lateral non-accidental injury.
Yeah, so if you will consider it like non-accidental injury, so posterior rib fracture, and it is near the costovertebral junction, and you can expect it from the way how this mechanism happened, right? Mechanism of fracture, right? Yeah, and maybe if you are lucky, you can maybe see like fracture also in there. So maybe edges, more edges of fractures, that one with periosteum, one without, one with callus. So this means that this patient underwent many fractures, right? So again, when you find metaphyseal fracture, or you can say that bucket handle fracture, it is the one that you expect to mention non-accidental injury. Then when you go to the skull of this patient, what you are going to see, Roa, I see your question now about this.
Skull fracture?
Yes, skull fracture. With the position here. Yeah. So it is like in the left frontal region. Yes. Superior to the orbital rim. So here. So it can be everywhere, but they like the parietal. Yeah. So highly specific fracture, either metaphyseal or rib fracture, or maybe something like SSS, scapula sternum spinous process. Then if you did CT brain and you find this one, again it will be child abuse. Yes. So what do you expect here? What do you see here? Can you describe it?
Subdural hematoma with the skull fracture.
Yeah, so there is a fracture in the skull, perfect, and subdural hematoma and subdural collection or hygroma and cerebral brain, perfect, cerebral contusion. So all this, when you find, sure that abuse, non-accidental injury. And when you find something like this, how you describe it?
Subdural hematoma.
Subdural hematoma. You can see the high density or fresh blood density. And also you can see something here. Yes, interhemispheric. Perfect. interhemispheric fissure in the posterior aspect. So subdural hematoma. The non-accidental injury in any exam is very, very popular. They like it. So be prepared that you will be asked about it. What happened here? This pediatric patient?
Could be ischemic.
Yes, ischemic, maybe ischemic injury. How you describe it? What happened here? Can you see any
Right cerebral
characterization?
hemisphere.
Yes. So
Loss of the gray-white matter differentiation. Brain edema.
Perfect.
Midline shift.
Yeah. And you can see the hypoattenuation of the right cerebral hemisphere, like low density cerebral hemisphere. And you will consider that maybe also the gray matter differentiation is lost, right? The ventricle, when you describe it, you will describe that there is also some compression, or you cannot see it well, right? And the falx here, what happened with the falx? There is some
subfalcine herniation.
Yeah, some bowing, or you can consider it as herniation. So all this criteria, it can be ischemia, and also maybe you can see that maybe subarachnoid something, subarachnoid effacement. So could be subarachnoid hemorrhage as well, right? So finally, your description will include all this. Then you can suggest something like acute injury, ischemic injury. Then all this criteria, not enough? Yes, not enough. Maybe you can find others. Like here, when you find a pediatric patient and you go through the CT of the patient and you find something in the abdomen. What is here?
Hepatic laceration.
Yes, you can find something going in the solid organs, including the liver or the pancreas. Like here is swollen. So the liver here have liver injury or laceration. Perfect. And here you can find the pancreatic swelling. And if there is trauma, it will be pancreatic edema and contusion. And finally, they like it in the MCQ, what you can find it in the
duodenal hematoma.
Duodenal, perfect, duodenal injury. How you know this? Because it is dilated and full of fluid, right? And you can see
thick
that
wall.
there is some thickening, yeah, in the wall. So also, if you go to the pouches, which you are in the ultrasound and you go to check for them, you can find some fluids. So this means that there is injury in the hepatorenal pouch or in the lienorenal or paracolic, left paracolic gutter, right? Perfect. Yes. Okay. I think just to mention that sometimes something like periostitis can see about 1 week post-trauma. Then you will think about what is called differential of periostitis in infant, either physiological, diaphyseal, smooth symmetrical like this, or Caffey syndrome, uroblastoma, Metz-Torch syphilis. Differential diagnosis important to know. Okay. When you find multiple fractures, you will think about either non-accidental injuries, but also maybe there is something congenital like osteogenesis imperfecta, right? And neuromuscular disorders, something like this syndrome, or congenital insensitivity to pain. So what it will be this one?
Osteogenesis imperfecta.
Why? How you can know it?
First of all, degrees bone density, generalized degrees in bone density, and
Perfect,
multiple
Alaa.
fractures.
And Wormian bone on the skull.
Wormian skull, perfect.
And thinning of the scalp and osteogenesis imperfecta.
Okay, what else?
Irregularity and bowing of the bones.
Yes. Variable fractures with multiple ages as well. Yes. And as you mentioned, also the skull shape can be like bell-shaped skull, bell-shaped chest. Maybe all this give you the impression that it will be osteogenesis imperfecta. Yes, Alaa, there is left inguinal hernia as well. Yes. I think I want to show you before we finish just something interesting again before we shift to GI. Okay. So let's go to some hybrid imaging, and now your choice to describe the finding this patient had. So this bed CT, FDG bed CT of this patient, so if you make it for the child, then make that they have something, very nice indication to do it. So how you will start? You start with the liver, that's a good choice. So yeah, when you find multiple hepatic lesions with
para-aortic lymph node,
para-aortic lymph nodes, maybe
right posterior occipital lymph node, group 5, level 5.
This one, okay. What else?
Hyper dense.
Nermeen, nice.
Left iliac.
Differential. And Alaa, left iliac bone. Okay, I agree with you. Continue, Marwa. Marwa, continue. Yes, okay. We are hearing you.
Vertebral lumbar L5, L4 vertebra.
Okay, this one, yes. So there is like a bone lesions and there is liver lesions. Yeah, nice. And there is subcutaneous. You can consider it as a nodal lesion. And look in this one. Maybe it is outside the liver. So if it is outside the liver, where you consider it? What this structure is going here? Alaa, perfect. It can be the pancreas. Sure, if you go in this case, you will go and check image by image, and you will see the where exactly. Also here, maybe something in the lung, right? So now you have pediatric patient. I can tell you the age is about 14 years old with bone, lung, and maybe some odd metastasis like in pancreas. And so what is your differential? You need something very aggressive. I see Nermeen, she's clever, our star. She put leukemia and lymphoma as good differential. But when you find that the liver is much affected, do you agree that maybe it is the primary there? Do you like to check something in this clinical laboratory of this patient? What you will ask? And if you find something, what you are going to consider? Heba. I am searching in the answers you put. Is this anyone put this differential, which is very important to put maybe as a first differential. If you find, I can give you the answer if I tell. Yeah, perfect. If you find the liver lesion, either it is metastatic or primary. So if it is primary, then you consider it as Nermeen, perfect. Ala, yes, nice. Our stars. So it will be hepatoblastoma. Yes, hepatoblastoma. So the most important to look for the age and for the aggressiveness. In the clinical laboratory, you will check for the alpha fetoprotein. If it is high, as you mentioned, then you are going to mention that could be hepatoblastoma. So, do you agree that if not hepatoblastoma, it can be like leukemia, lymphoma, which is different management? So you should be sure what it could be. Okay. Let's go to this
I'd like to
patient.
ask, sorry, I'd like to ask a question, please.
Yes.
To Mahmoud. How can we differentiate hepatoblastoma? What's the relation between hepatoblastoma and the metastatic lung lesion, which is seen at the right lung? And pancreatic, what about the pancreatic lesion?
When you see this odd metastasis, and you see also the aggressiveness of this tumor that give like everywhere bones and so on, with the age of this patient, you will put differential. You agree with me?
Also lymph node?
Yeah, you will put differential of leukemia, lymphoma, and so on. But don't forget that the liver lesion, that's what I want to, the teaching point here, that the liver lesion, especially you see the uptake is very high, and some of these lesions are necrotic. Maybe this is the primary. So when you find large primary lesion, it could be primary or secondary. I agree with you. If it is primary, it would be hepatoblastoma. So we are going to check the clinical and previous imaging, and including the alpha fetoprotein. So if you find it very high, then you are going to mention that hepatoblastoma until proved otherwise, right? So it cannot be just one image, but the calibration or the like you should collect all the data, then go to one top list differential and other less common differential. So one of the good differential here that you cannot put hepatic endothelioma. Why? Because you have very aggressive lesion, and the endothelioma it like behavior of what? We will go in this if you will go in the presentation later on. But you remember that it is like hemangioma exactly, but with big heart and big circulation. We will talk about this later on. That you will find that this patient almost have something in the circulation with high cardiac output and have something like cardiomegaly with shunt and so on. Okay, so you cannot put it because already you have metastasis everywhere. Okay, let's go to this patient, and I can tell you which is it will be the key. But let's go to this patient in this image first, which is the FDG PET-CT. And I just move a bit like this. Yes, oops. Okay, so I show you the answer with my movement, but okay. How you can describe this? Look in the iliac bone. So this is something to mention here, that there is high uptake in the iliac bones, right? Right iliac bone. Yeah. And what he won't show you here? Something maybe in the bowel. Okay. Could be physiological. Could be physiological, the bowel. It can be physiological, right? Okay. So what about the yeah? Yes. This patient, 6 years old, male patient. I will show you the answer directly because it's not mud. This examination is MIBG. Yeah. When he did MIBG, he find this high uptake, right? Abnormal uptake in the right iliac bone. So MIBG which tumor you are looking for mainly? Yeah, perfect. And one of them, which is like this patient, it is neuroblastoma. Yeah, and it's like the bone send metastasis to the bone. So when he did PET-CT, FDG PET-CT, he confirmed that this focal abnormality in the right iliac bone and also the lymph node accumulation in the upper. Yes, so it is neuroblastoma. Perfect. Metastatic neuroblastoma to the bone. Okay. Yeah, and without history you cannot reach, I know. Okay, so that's why I show you the answer. Yeah. So if you describe this one from the CT image, you can try.
Hyperdense lesion.
You can consider it like this, and how you describe these changes. Yes. So this patient within the pediatric age group, he have lesion. Can you see any changes in the bone, overlying bone, the calvareal bone? Nice, Nermeen, perfect. Metastasis from neuroblastoma would be very nice differential. And what else you can put rather than metastasis? Eosinophilic granuloma, nice, perfect. Langerhans. So metastasis, okay. What it will be the other differential? Let's try to describe this lesion, which is lesion like should be like extra axial lesion, look like this, and you can see the affection of the bone. Yeah. And
Meningioma.
FDJ, it have high uptake. Do you agree that this patient with this age group is rare to have this type of tumor, right? Which is not in pediatric age group, right? The meningioma is far from to be included in the pediatric age group differentiation, right? So I agree with you that you can put Langerhans in differential, you can put metastasis from neuroblastoma, and I see Nermeen, I think, no, not Nermeen. Hawawi, what you want to put? Tell me. Okay.
Hematoma.
Perfect. Yeah, you should put lymphoma. Don't forget it. Always. Lymphoma and metastasis, they are like sisters, brothers, whatever. Put them together always. Okay. So you can see that there is lesion and destructive lesion. So again, lymphoma, it will be included in differential. And this patient was lymphoma. Yes. So hemangiopericytoma, but again, the age group. You can see that this patient is very young, 30 month female patient, so he's young. Yes, lymphoma is one of the good differential, you can put it. I think we have about 7 minutes, maybe we can, okay. We can see this case. Try to find solution for this case. So how does the skull appear? Yeah, try to, you can see the skull and try to find that he's young age, right? So do you see any abnormality? Look in just X-ray first. Yeah. Try to describe the X-ray, then maybe you will get the answer. So you find like some lytic lesions in the skull, okay? So lytic lesion in the skull, what you are going to put differential from the X-ray just. Then if you go to the CT, again, the lytic lesion, and he want to show you something here. So our star mentioned the EG, Ala, Reem, Nermeen, yeah. So EG, it will be good differential. Metastasis again will be differential. But the EG, as you mentioned, with lytic appearance, it will be good differential, okay? Very nice differential, especially if you find what is called vertebra plana. Yes, you can see that there is multiple level of EG, vertebra plana. Perfect, Ala. So with vertebra plana, mention EG as one of the good differential. You can put it as, yeah, one of the best differential. Okay? Langerhans cell histocytosis, lytic lesions, go like your approach normal. Hiba, revise because this patient is very young. Okay? So metastasis, okay. EG, okay. Metastasis either, okay? So the age here is very important. Look in the skull, try to figure out, is it like young patient or old? I think he's young, very young. So about 2 years. This one is a bit difficult, but okay. Let's mention that this patient is 10 years old and he did this appearance, and you can see that there is pulmonary lesion here. Again, the liver, you can see that there is some high uptake here, and in the MIB image of the PET CT, you can see something. We have about 4 minutes to finish. So liver, pulmonary lesions, liver lesions. Okay, I see again. Okay, perfect. You think about that maybe something going in the adrenal gland.
Adrenal lesion.
Left adrenal, yes. So what is going in the left adrenal?
High uptake.
Very high uptake. Yeah. And even
Maybe.
it's into liver and pulmonary. And you can see the appearance here, yeah. So when you remember when we mentioned when you go to the adrenal lesions, that when you find very high lesion, and it is ugly high lesion, yes, Rabab, welcome, yes. So it can be what is called adrenocortical cancer, yeah, and it happened in this age. Perfect. So don't forget it. Yeah, it's a bit difficult, but yeah, liver, hepatoblastoma, adrenocortical lesion. The age is about 10 years, and you can expect this from the MIB that he is a young patient. Okay. I don't think that we can take this patient already. Okay. We have 2 minutes. Okay, we can take it quickly. I think this one is easier one. We can finish with it. Just the most important to mention the metastasis.
Osteosarcoma metastasis to the lung.
Lung.
With any more thorax.
Yeah, lung.
Yes.
Okay, and
lung and the bone.
And what?
Iliac.
Okay, osteosarcoma, I agree. Metastatic.
Axillary.
The differential may be Ewing, but the site and I told you that around the knee, so it's the most important differential will be osteosarcoma. So search for skip. Don't forget your approach going well. Go search for skip lesions. So skip lesions will be in the same axis probably. So,
iliac bone.
Yes, you go and search for example, if there is something going with the right femur, and if there is any lymphadenopathy, and finally for the okay,
lung metastasis. Yes,
lung metastasis. So it is sarcoma, and they mentioned that there is right femoral tumor, skip lesion. The primary, the osteosarcoma, and there is metastasis for the lung, and some lymph node, which is maybe, I don't know, maybe here, but I'm not sure because this could be, yeah, maybe
Axillary.
and right axillary. I agree with you, but يعني not very high uptake, but okay.
Yes. Thank you, Dr. Mahmoud.
I hope everyone enjoy this lesions and this sorry hybrid and
very interesting, like very interesting cases.
okay. Inshallah.
Thank
next.
you, Mahmoud.
Yeah. Okay. Enjoy and
شكرا يا محمود.
okay. See you inshallah.
It's
Okay.
see you.
Yeah. See you inshallah. Assalamu alaikum.
عليكم السلام.